Welcome to Pharmacology Mastery 2025. Rocket here are 50 high-yield Nclex pharmacology questions with full rationales and strategies. These questions are crafted to help you think like the Nclex, stay safe as a nurse, and master key medications. Stick around until the end, you'll get the answers, rationales, and test-taking strategies you need. Let's begin. Question 1. A client with atrial fibrillation is started on warfarin and amiodarone. Which change is most likely and requires immediate nursing action? A. INR decreases. B. INR increases significantly. C. Potassium increases. D. Platelet count drops. Answer: B. INR increases significantly. Rationale: amiodarone inhibits warfarin metabolism, increases INR/bleeding risk. Strategy: whenever a patient starts amiodarone while on warfarin, expect higher INR, anticipate holding or lowering warfarin. Question 2. A patient with renal failure, CrCl 20 ml per minute, is prescribed metformin for type 2 DM. What is the priority? A. Give usual dose. B. Reduce dose by half. C. Hold metformin. D. Increase dose due to insulin resistance. Answer: C. Hold metformin. Rationale: metformin contraindicated / should be held in severe renal impairment due to lactic acidosis risk. Strategy: always check renal function before starting or continuing metformin. Question 3. A patient on digoxin and furosemide develops muscle weakness and PVCs, serum K plus equals 3.0 milliequivalent/L. What explains the symptoms? A. Hypokalemia increases digoxin toxicity. B. Furosemide prevents digoxin absorption. C. Hyperkalemia potentiates digoxin. D. Furosemide causes digitalis to be ineffective. Answer: A. Hypokalemia increases digoxin toxicity. Rationale: low K plus enhances digoxin binding to Na plus/K plus ADPase toxicity, arrhythmias, GI, visual. Strategy: in patients on digoxin plus loop diuretics, monitor potassium vigilantly. Question 4. Which antibiotic requires serum level monitoring to ensure therapeutic but non-toxic dosing in renal impairment? A. Ceftriaxone. B. Vancomycin. C. Azithromycin. D. Doxycycline. Answer: B. Vancomycin. Rationale: vancomycin is nephrotoxic and requires trough, or AUC, monitoring, dose adjust for CrCl. Strategy: for nephrotoxic/renally excreted antibiotics, plan serum levels. Question 5. A pregnant patient, first trimester, asks about taking ACE inhibitors for HTN. You should: A. Continue, low teratogenic risk. B. Switch to methyldopa or labetalol. C. Increase dose for safety. D. Add spironolactone instead. Answer: B. Switch to methyldopa or labetalol. Rationale: ACE inhibitors are teratogenic, renal dysplasia, oligohydramnios, avoid in pregnancy. Strategy: remember ACEI/ARBs equals contraindicated in pregnancy, use pregnancy-safe alternatives. Question 6. Which antidote is correct for severe bleeding from a direct thrombin inhibitor, dabigatran? A. Vitamin K. B. Idarucizumab. C. Protamine sulfate. D. Andexanet alpha. Answer: B. Idarucizumab. Rationale: idarucizumab is the specific reversal agent for dabigatran. Strategy: match DOAC to their reversal agents, dabigatran idarucizumab. Question 7. A patient receiving 4 magnesium sulfate for preeclampsia becomes drowsy and respiratory rate is 8 per minute. Next action: A. Give calcium gluconate 4. B. Increase infusion rate. C. Give naloxone. D. Place on oxygen only. Answer: A. Give calcium gluconate 4. Rationale: magnesium toxicity causes respiratory depression, calcium gluconate is the antidote. Strategy: for magnesium toxicity, loss of reflexes, respiratory depression, give calcium. Question 8. A client on warfarin with elevated INR and active bleeding, which agent is fastest to reverse warfarin? A. Vitamin KPO. B. Fresh frozen plasma, FFP. C. Prothrombin complex concentrate, PCC. D. Desmopressin. Answer: C. Prothrombin complex concentrate, PCC. Rationale: PCC rapidly restores clotting factors, faster than FFP or oral vitamin K. Strategy: for life-threatening warfarin bleeding, PCC plus or minus 4 vitamin K. Question 9. A patient started on phenelzyne, MAOI, eats aged cheese and develops severe headache and hypertension. This is due to A. Serotonin syndrome. B. Hypertensive crisis from tyramine interaction. C. Anticholinergic toxicity. D. Withdrawal from MAOI. Answer: B. Hypertensive crisis from tyramine interaction. Rationale: MAOIs plus tyramine catecholamine release hypertensive crisis. Strategy: teach strict tyramine avoidance with MAOIs. Question 10. Which cardiac drug is most likely to cause torsades de pointes in a patient with prolonged QT? A. Amiodarone. B. Sotalol. C. Lisinopril. D. Metoprolol. Answer: B. Sotalol. Rationale: sotalol prolongs QT and can precipitate torsades. Amiodarone also prolongs QT but less torsadogenic risk compared to sotalol. Strategy: watch QT interval for class 3 agents and certain non-antiarrhythmics, macrolides, fluoroquinolones. Question 11. Which antihypertensive is contraindicated in a patient with bilateral renal artery stenosis? A. ACE inhibitor, e.g., lisinopril. B. Calcium channel blocker, e.g., amlodipine. C. Beta blocker, metoprolol. D. Hydralazine. Answer: A. ACE inhibitor, e.g., lisinopril. Rationale: ACE inhibitors can precipitate renal failure in bilateral renal artery stenosis. Strategy: if renal artery stenosis suspected, avoid ACEI/ARB. Question 12. A nurse prepares to give intravenous phenytoin rapidly. Which complication is most important to avoid? A. Hypotension and cardiac arrhythmia. B. Hyperglycemia. C. Ototoxicity. D. Respiratory alkalosis. Answer: A. Hypotension and cardiac arrhythmia. Rationale: rapid 4-phenytoin can cause hypotension, bradycardia, arrhythmias, give slowly and monitor cardiac status. Strategy: for 4-phenytoin, use proper rate, less than 50 mg per minute in adults, cardiac monitoring. Question 13. Which medication interaction increases risk of serotonin syndrome? A. SSRI plus MAOI. B. SSRI plus furosemide. C. SSRI plus statin. D. SSRI plus metformin. Answer: A. SSRI plus MAOI. Rationale: combining serotonergic drugs, SSRI plus MAOI, SSRIs plus SNRIs, tramadol, linezolid, risk serotonin syndrome. Strategy: avoid combining too strong serotonergic agents, observe for hyperreflexia, clonus, autonomic instability. Question 14. A patient on lithium presents with tremor, confusion, and ataxia. Serum lithium level is 2.0 milliequivalent/L. Best initial nursing action. A. Encourage fluids and hold lithium. B. Increase lithium dose. C. Give furosemide. D. Start hemodialysis immediately for any level greater than 1.5. Answer: A. Encourage fluids and hold lithium. Rationale: lithium toxicity signs at higher levels, hold med and hydrate, hemodialysis considered for severe toxicity, renal failure, or very high levels. Strategy: lithium has narrow therapeutic index, check levels and renal status. Question 15. Which anticonvulsant is highly teratogenic and associated with neural tube defects? A. Lamotrigine. B. Valproic acid, valproate. C. Levetiracetam. D. Gabapentin. Answer: B. Valproic acid, valproate. Rationale: valproate associated with neural tube defects and developmental delays, avoid in pregnancy. Strategy: for women of childbearing age, consider safer alternatives and counsel. Question 16. A patient with severe C. difficile infection is failing oral vancomycin. Which antibiotic is indicated next? A. For vancomycin. B. Fidaxomicin or fecal transplant. C. Oral metronidazole only. D. Ceftriaxone. Answer: B. Fidaxomicin or fecal transplant. Rationale: fidaxomicin is effective for refractory C. diff, fecal microbiota transplant for recurrent disease. For vanco does not reach gut lumen. Strategy: remember route matters, oral vancomycin for C. diff, for vanco won't treat gut infection. Question 17. Which inhaled bronchodilator can cause hypokalemia when given in high doses? A. Ipratropium. B. Albuterol, beta-2 agonist. C. Beclomethasone. D. Monteliacast. Answer: B. Albuterol, beta-2 agonist. Rationale: beta-2 agonists shift potassium into cells, hypokalemia risk with high-dose nebulized beta-2 agonists. Strategy: in severe asthma with frequent beta-2 agonists, monitor K+. Question 18. A patient on heparin develops sudden thrombocytopenia, platelets fall by 50%, and new thrombosis. What's the diagnosis and next step? A. Heparin-induced thrombocytopenia, HIT, stop heparin and start argatroban. B. ITP, give steroids. C. DIC, give platelets. D. Warfarin necrosis, give vitamin K. Answer: A. Heparin-induced thrombocytopenia, HIT, stop heparin and start argatroban. Rationale: HIT is immune-mediated, prothrombotic, stop all heparin and start direct thrombin inhibitor. Strategy: watch for 5 to 10 day platelet drop plus thrombosis after heparin exposure. Question 19. Which statin interaction substantially increases statin levels and risk of rhabdomyolysis? A. Simvastatin plus clarithromycin. B. Simvastatin plus aspirin. C. Simvastatin plus metformin. D. Simvastatin plus lisinopril. Answer: A. Simvastatin plus clarithromycin. Rationale: macrolides inhibit CYP3A4, increase simvastatin levels, myopathy/rhabdo risk. Strategy: avoid CYP3A4 inhibitors with simvastatin/atorvastatin, prefer pravastatin/rosuvastatin if needed. Question 20. A patient taking tetracycline asks about toothpaste with fluoride. What do you advise? A. No interaction, okay to use. B. Avoid dairy and antacids when taking tetracyclines. C. Fluoride causes toxicity with tetracycline. D. Tetracycline must be taken with calcium to enhance absorption. Answer: B. Avoid dairy and antacids when taking tetracyclines. Rationale: tetracyclines chelate with divalent cations, calcium, magnesium, iron, aluminum, reduce absorption. Fluoride toothpaste topical is fine. Avoid oral calcium/antacid near dosing. Strategy: teach timing, take tetracyclines 1 to 2 hours before or after meals/antacids. Question 21. Which medication requires a slow 4-push to prevent severe bradycardia and hypotension? A. Vancomycin. B. Phenytoin. C. Calcium gluconate. D. Intravenous amiodarone. Answer: B. Phenytoin. Rationale: rapid 4-phenytoin can cause cardiovascular collapse, give slowly with monitoring. Strategy: check recommended rates for 4 medications, phenytoin less than 50 mg per minute. Question 22. A patient on clozapine develops fever, sore throat, and malaise. Which lab test is priority? A. Serum lithium level. B. CBC with differential, ANC. C. Liver panel. D. TSH. Answer: B. CBC with differential, ANC. Rationale: clozapine can cause agranulocytosis, neutropenia risk, need immediate ANC check. Strategy, monitor CBC per protocol for clozapine therapy. Question 23. Which anticoagulant does not require routine INR monitoring? A. Warfarin. B. Apixaban, DOAC. C. Heparin infusion. D. Femprocuman. Answer, B. Apixaban, DOAC. Rationale, direct oral anticoagulants have predictable dosing and do not require routine INR monitoring. Strategy, no differences, warfarin INR, DOAC's renal dosing, but no routine INR. Question 24. Which acid-base change is expected with high-dose salicylate, aspirin, overdose? A. Metabolic acidosis early, respiratory alkalosis later. B. Respiratory alkalosis early, metabolic acidosis later. C. Pure metabolic alkalosis. D. Pure respiratory acidosis. Answer, B. Respiratory alkalosis early, metabolic acidosis later. Rationale, salicylates stimulate respiratory center, hyperventilation early respiratory alkalosis, then cause metabolic acidosis. Strategy, in aspirin OD, expect mixed acid-base disturbance and manage accordingly. Question 25. Which immunization is contraindicated in a patient receiving high-dose systemic corticosteroids? A. Inactivated influenza vaccine. B. Pneumococcal conjugate vaccine. C. Live attenuated varicella vaccine. D. TAP. Answer, C. Live attenuated varicella vaccine. Rationale, live vaccines are contraindicated in immunosuppressed patients due to risk of infection. Strategy, for immunocompromised, avoid live vaccines. Question 26. A patient on linezolid for VRE therapy becomes hypertensive after eating aged cheese. Why? A. Linezolid MAOI effect causes hypertensive crisis with tyramine-rich foods. B. Linezolid causes ACE-like effects. C. Interaction with calcium-rich foods. D. Linezolid inactivates tyramine. Answer, A. Linezolid MAOI effect causes hypertensive crisis with tyramine-rich foods. Rationale, linezolid has weak MAOI activity, tyramine-rich foods can cause hypertensive reaction. Strategy, counsel on tyramine avoidance with linezolid. Question 27. Which drug commonly causes red-orange body fluids and can stain contact lenses? A. Rifampin. B. Levofloxacin. C. Isoniazid. D. Ethambutol. Answer, A. Rifampin. Rationale, rifampin causes orange/red discoloration of urine, tears, sweat. Can stain contacts. Strategy, warn patients about harmless discoloration. Question 28. A patient on fluconazole and warfarin has an INR rise. What is the mechanism? A. Fluconazole induces CYP enzymes decreased warfarin effect. B. Fluconazole inhibits CYP enzymes increased warfarin levels. C. Fluconazole increases vitamin K absorption. D. Fluconazole has no interaction. Answer, B. Fluconazole inhibits CYP enzymes increased warfarin levels. Rationale, azoles inhibit CYP450 reduce warfarin metabolism INR. Strategy, watch for azole-warfarin interactions, lower warfarin dose as needed. Question 29. Which opioid is contraindicated with MAO inhibitors due to risk of severe reactions? A. Morphine. B. Meperidine, pethidine. C. Fentanyl. D. Codeine. Answer, B. Meperidine, pethidine. Rationale, meperidine plus MAOI can precipitate serotonin syndrome and hyperpyrexia. Strategy, avoid meperidine with MAOIs and consider alternatives. Question 30. A patient with sepsis and poor perfusion has low urine output. Which antibiotic dosing issue is most critical? A. Hydrophilic antibiotics may have lower tissue penetration, need loading doses and renal adjusted dosing. B. Lipophilic antibiotics are cleared renally. C. All antibiotics should be stopped. D. Oral dosing preferred. Answer, A. Hydrophilic antibiotics may have lower tissue penetration, need loading doses and renal adjusted dosing. Rationale: in sepsis, volume of distribution changes, hydrophilic drugs, aminoglycosides, beta-lactams, may require loading and careful renal dosing. Strategy: in altered physiology, assess VD and renal function, adjust antibiotic strategy. Question 31. Which medication is associated with pancreatitis and should be considered if lipase is elevated? A. Propofol. B. Valproic acid. C. Amoxicillin. D. Lisinopril. Answer: B. Valproic acid. Rationale: valproate can cause pancreatitis, elevated lipase warrants evaluating meds. Strategy: if new pancreatitis, review anticonvulsants and other high-risk drugs. Question 32. Which antiemetic carries a risk of QT prolongation and should be used cautiously in patients with prolonged QT? A. Ondansetron. B. Metoclopramide. C. Promethazine. D. Dexamethasone. Answer: A. Ondansetron. Rationale: 5-HT3 antagonists like ondansetron can prolong the QT interval. Strategy: check QT before giving multiple QT prolonging agents. Question 33. Which insulin regimen most closely mimics physiologic insulin secretion and is preferred for intensive glycemic control? A. Basal bolus, long-acting plus rapid-acting. B. Sliding scale alone. C. NPH bid only. D. Premixed insulin only. Answer: A. Basal bolus, long-acting plus rapid-acting. Rationale: basal bolus replicates basal insulin plus prandial coverage, sliding scale alone is reactive and inferior. Strategy: for tight control, use basal bolus rather than sliding scale monotherapy. Question 34. Which drug class is most associated with tendon rupture, ESP Achilles tendon, especially in older adults? A. Macrolides. B. Fluoroquinolones. C. Beta-lactams. D. Aminoglycosides. Answer: B. Fluoroquinolones. Rationale: fluoroquinolones increase risk of tendinitis/tendon rupture, especially with steroids or elderly. Strategy: avoid fluoroquinolones in high-risk patients if alternatives exist. Question 35. A patient with migraine is on sumatriptan and complains of chest tightness. What's the concern? A. Coronary vasospasm, contraindicated in CAD/ischemic heart disease. B. Anxiety disorder only. C. Hypoglycemia. D. Pulmonary embolism. Answer: A. Coronary vasospasm, contraindicated in CAD/ischemic heart disease. Rationale: triptans cause vasoconstriction, can precipitate coronary vasospasm/ischemia. Strategy: screen for cardiac risk before prescribing triptans. Question 36. Which chemotherapy drug causes hemorrhagic cystitis and requires mesna as prophylaxis? A. Cyclophosphamide, ifosfamide. B. Doxorubicin. C. Vincristine. D. Methotrexate. Answer: A. Cyclophosphamide, ifosfamide. Rationale: acrolein metabolite causes hemorrhagic cystitis, mesna binds acrolein. Strategy: with certain alkylators, plan mesna and hydration. Question 37. Which drug class is first line for status epilepticus? A. Benzodiazepines, e.g., lorazepam. B. SSRIs. C. Beta blockers. D. Antipsychotics. Answer: A. Benzodiazepines, e.g., lorazepam. Rationale: rapid-acting benzodiazepines terminate seizures, then long-acting anticonvulsant follows, phenytoin, levetiracetam. Strategy: for status, give 4 lorazepam/IM midazolam promptly. Question 38. Which medication can cause optic neuritis and decreased visual acuity as a serious adverse effect? A. Ethambutol. B. Isoniazid. C. Rifampin. D. Pyrazinamide. Answer: A. Ethambutol. Rationale: ethambutol can cause optic neuritis, monitor visual acuity and color vision. Strategy: baseline and periodic vision checks when using ethambutol. Question 39. A hospitalized patient receives tetracaine drops and becomes bradycardic and hypotensive. The mechanism is likely A. Systemic absorption causing local anesthetic toxicity myocardial depression. B. Anaphylaxis only. C. Topical steroid side effect. D. Anticholinergic effect. Answer: A. Systemic absorption causing local anesthetic toxicity myocardial depression. Rationale: topical ophthalmic anesthetics can be absorbed and cause systemic toxicity including CV depression. Strategy: be cautious with topical anesthetics in large amounts or compromised mucosa. Question 40. A patient on statin plus fibrate, gemfibrozil, develops muscle pain, weakness, and CK markedly elevated. Best action: A. Stop both drugs immediately and evaluate for rhabdomyolysis. B. Continue, muscle pain common but benign. C. Add colchicine. D. Switch to high-dose simvastatin. Answer: A. Stop both drugs immediately and evaluate for rhabdomyolysis. Rationale: combination increases risk of myopathy/rhabdomyolysis, stop meds and assess renal function/CK. Strategy: avoid combining gemfibrozil with statins when possible. If necessary, choose lower-risk combos. Question 41. Which antihyperglycemic increases risk of genital mycotic infections and is contraindicated in severe renal impairment? A. Metformin. B. SGLT2 inhibitors, e.g., canagliflozin. C. Sulfonylureas. D. DPP4 inhibitors. Answer: B. SGLT2 inhibitors, e.g., canagliflozin. Rationale: SGLT2 inhibitors cause glycosuria, increased genital yeast infections, require adequate renal function. Strategy: counsel on hygiene, avoid in severe renal impairment. Question 42. Which medication for Parkinson's disease may cause impulse control disorders, pathological gambling, hypersexuality? A. Levodopa-carbidopa. B. Dopamine agonists, e.g., pramipexole, ropinirole. C. MAOB inhibitors only. D. Anticholinergics. Answer: B. Dopamine agonists, e.g., pramipexole, ropinirole. Rationale: dopamine agonists are associated with impulse control disorders. Strategy: screen and counsel patients/family about behavioral changes. Question 43. A patient taking terbinafine for onychomycosis develops jaundice and pruritus. Which is most appropriate? A. Stop terbinafine and check LFTs, risk of hepatotoxicity. B. Continue, harmless side effect. C. Add acetaminophen daily. D. Switch to topical terbinafine. Answer: A. Stop terbinafine and check LFTs, risk of hepatotoxicity. Rationale: terbinafine can cause hepatotoxicity, stop if signs of liver injury. Strategy: baseline and periodic LFTs for systemic antifungals if indicated. Question 44. Which drug is associated with red man syndrome if infused too rapidly? A. Vancomycin. B. Penicillin. C. Ciprofloxacin. D. Gentamicin. Answer: A. Vancomycin. Rationale: rapid infusion causes histamine-mediated flushing, hypotension, slow infusion and antihistamines help. Strategy: infuse vancomycin over recommended time, at least 60 minutes, and pre-medicate if needed. Question 45. Which antiplatelet agent irreversibly inhibits the P2Y12ADP receptor on platelets and requires several days to restore platelet function after stopping? A. Clopidogrel. B. Aspirin. C. Heparin. D. Warfarin. Answer: A. Clopidogrel. Rationale: clopidogrel irreversibly inhibits P2Y12 platelets affected for a lifespan, 7-10 days. Strategy: stop clopidogrel several days pre-op if possible. Question 46. Which medication is most likely to cause SIAD and hyponatremia? A. Lithium. B. SSRIs, e.g., sertraline. C. ACE inhibitors. D. Calcium channel blockers. Answer: B. SSRIs, e.g., sertraline. Rationale: SSRIs can cause SIADH, especially in elderly, leading to hyponatremia. Strategy: monitor NA plus in older adults starting SSRIs or on other hyponatremia risk meds. Question 47. A patient being treated with heparin for DVT suddenly developed chest pain and shortness of breath. Heparin has been used for 7 days and platelets fell by 60%. What is the most concerning diagnosis? A. Pulmonary embolism from HIT-induced thrombosis. B. MIM related to meds. C. Anxiety attack. D. Allergic reaction to heparin. Answer: A. Pulmonary embolism from HIT-induced thrombosis. Rationale: HIT can cause paradoxical thrombosis, falling platelet count plus new thrombosis suggests HIT. Strategy: stop heparin, start non-heparin anticoagulant, get HIT testing. Question 48. Which chemotherapy agent causes dose-limiting cardiomyopathy, dilated, and requires cumulative dose monitoring? A. Doxorubicin, anthracyclines. B. Cisplatin. C. Vincristine. D. Methotrexate. Answer: A. Doxorubicin, anthracyclines. Rationale: anthracyclines cause cardiomyopathy, monitor cumulative dose and cardiac function. Strategy: baseline ejection fraction and monitoring during therapy. Question 49. A patient receiving warfarin is started on rifampin for TB. What effect on warfarin dose is expected? A. Need to increase warfarin dose, rifampin induces CYP450. B. Need to decrease warfarin dose. C. No change. D. Stop warfarin. Answer: A. Need to increase warfarin dose, rifampin induces CYP450. Rationale: rifampin induces CYP enzymes, increases warfarin metabolism, lower INR, need higher warfarin dose. Strategy: anticipate and monitor INR more frequently when starting/stopping CYP inducers. Question 50. A hospitalized patient with severe asthma is given 4-aminophyline and develops arrhythmias and seizures. Which lab should be checked urgently? A. Theophylline, aminophyline, level. B. Potassium only. C. Glucose only. D. INR. Answer: A. Theophylline, aminophyline, level. Rationale: aminophyline/theophylline has narrow therapeutic index, toxicity causes seizures, arrhythmias, check serum level and treat, activated charcoal/hemodialysis. Strategy: for narrow TI drugs, monitor levels and watch for signs of toxicity. If you made it this far, you've just tackled some of the toughest medication scenarios that could appear on your exam. Remember, NCLEX isn't just about memorizing drugs, it's about safety, prioritization, and critical thinking under pressure. Backhand index pointing right. Go back and review any questions that tripped you up, and keep practicing until the strategies become second nature. If this video helped you, don't forget to like, thumbs up, subscribe bell, and share with a fellow nursing student who's on the same journey. Stay focused, stay confident, and remember, you've got this. Flexed bicep sparkles. See you in the next video, and good luck on your NCLEX.